Good morning, and we'll get started. And we have a very useful and interesting presentation today. And actually, this is a study which was also done by the uh, Department of Pulmonary Medicine, in which they have documented with the help of many other departments, radiology, microbiology, etc., COVID-associated pulmonary aspergillosis, insights into a new disease. And though a lot of attention has been paid to mucormycosis during the time of COVID infections, um, um, but I think pulmonary aspergillosis was also increased because of the immunosuppression. And we will start the presentation now, and we will have questions at the end. Thank you.
Good morning, everyone. Myself, Dr. Prashant, Senior Resident from Department of Pulmonary Medicine. Today, we'll be presenting the CGR on a new disease entity, that is COVID-associated pulmonary aspergillosis, otherwise known as CAPA. So, as we all know, for the past couple of years, the world is under the pandemic caused by the COVID-19 virus. It has affected the lives of people around the globe. Though we are out of the pandemic waves, we are still living amidst of ripples of COVID. The complications and after effects of COVID are still a major health issue. So today we are presenting before you one such disease entity, which is the COVID-associated pulmonary aspergillosis. So I'll start my presentation with a case. This is regarding a middle-aged housewife who presented to us last month with complaints of cough with sticky hemoptysis for 2 months, breathlessness for 2 months, and a significant weight loss history, that is about 6 kg in past 2 months. She is a non-diabetic. She also gave history of COVID pneumonia 3 months back with ICU admission, and she received injectable glucocorticoids and oxygen support via face mask and intermittent NIV. The exact dose of injectable corticoids was not available, but she was discharged home on tapering doses of steroids over 6 weeks. She was discharged to home on room air. On general examination, when she presented to us, which was grossly normal, the systemic examination was showing bronchial breath sounds along with crepitations in the right infraclavicular area. This was the CT scan with which she presented with. It was showing bilateral upper lobe consolidation with cavitation. In fact, this patient was referred to us for evaluation of malignancy. So we did a bronchoscopy and bronchoalveolar lavage and a CT guided biopsy. The bronchoalveolar lavage microscopy showed septate acute angle branching hyphae, and the culture grew Aspergillus species. The BAL galactomenon was 4.3 and serum galactomenon was 1.7. Both the values were significant for invasive pulmonary aspergillosis. This is the image which shows polymorphonuclear infiltrates with septate acute angle branching hyphae. This is the high power field where we can see huge load of septate hyphae. This is the direct microscopy showing thin hyaline septate acute angle branching fungal hyphae of Aspergillus species. And this is the calcofluor white staining. So this patient with history of COVID infection is the setting of non-diabetic with CT features showing cavitation, consolidation with cavitation, which was histopathologically and microbiologically proven. So a diagnosis of definite CAPA was made. She was started on treatment with IV voriconazole and discharged on oral voriconazole for 3 to 6 months as per the radiological resolution. Her symptoms all subsided. Her hemoptysis, cough, and chest pain subsided, and she is doing well. So, as we all know, Aspergillus is a saprophytic conidial mold isolated abundantly from soil, construction dust, and hospitals. We all are exposed to this Aspergillus spores, but a very small proportion of us with altered immune system or underlying lung pathology has disease manifestation. This can extend from an hypersensitive reaction to infective manifestations. The fungal spores in the atmosphere on inhalation, if there is pulmonary defense insufficiency, these spores enter through the ciliated cells and through the basement membrane and causes disease manifestation. The spectrum of pulmonary aspergillosis extend from hypersensitive reaction, that is ABPA, to invasive pulmonary aspergillosis in immunocompromised patients to chronic pulmonary aspergillosis, that is in those patients who have underlying lung disease. This chronic pulmonary aspergillosis in itself is a spectrum of disease which includes aspergilloma, aspergillus nodules. This can be cavitary pulmonary aspergillosis or fibrosing aspergillosis, and later on it can also progress to subacute to invasive pulmonary aspergillosis. So, after the COVID pandemic in the early 2020, the first case report of invasive pulmonary aspergillosis in an otherwise immunocompetent patient who was suffering from COVID was reported by Philip Koller in the Journal of Mycosis. This was a new entity and it was termed COVID-19 associated pulmonary aspergillosis or CAPA. The major risk factors postulated were critical state ARDS, acute respiratory distress syndrome, requiring intensive care, treatment, and mechanical ventilation, underlying immune dysfunction, uncontrolled diabetes, and treatment with systemic corticosteroids and immunomodulators like tocilizumab. So, in patients with SARS-CoV-19, these virus affects the pulmonary defense mechanism. They affect the cells, the natural killer cells, gamma delta T cells, and as a result of this, these patients are more prone to fungal invasion. So when these patients inhale aspergillus spores, they are prone to COVID-associated pulmonary aspergillosis. The diagnosis of CAPA is based on clinical, radiological, and mycological features. As we all know, during the COVID pandemic, because of the barrier nursing care, the logistic issues, the stress and trauma of the healthcare workers, there was so much of restrictions in obtaining the adequate mycological samples, getting proper radiological investigations, and most of the clinical features were overlapping with the already dreaded COVID infection. So the clinical features for suspicion of COVID were persistent fever, cough with hemoptysis, breathlessness, and pleuritic chest pain. The radiological criteria include consolidation with bronchovascular distribution, appearance of a new consolidation patch while on treatment, multiple nodular lesions, rounded lung lesion with an enhancing center, or tree-in-bud pattern. Here we can see a consolidation along the bronchovascular distribution. This is the consolidation surrounded by a ground glass opacity, which is otherwise called the halo sign. This is the reverse halo sign, wherein there is central GGO and surrounded by dense consolidation. This is uh, usually reported more in mucormycosis, otherwise called the black fungus, but this is also very well seen in pulmonary aspergillosis, or rather mixed fungal infection. This is cavitating consolidation. Here you can see multiple nodules on bilateral lung fields which is cavitating. This is a dense consolidation with a cavity or air crescent changes inside. The mycological criteria for CAPA diagnosis include the biomarker studies and the microscopy and cultural studies. The biomarker studies include the galactomannan assay, manoprotein lateral flow assay, beta-D glucan assay, and the direct microscopy culture and Aspergillus PCR. Now coming to the CAPA appropriate test specimens. As you all know, the initial stages of pulmonary aspergillosis is bronchoinvasive, and to detect the disease in the initial stages, it is very important to get a representative lung sample. The lung biopsy is the only specimen which can demonstrate a definite or proven aspergillus infection. But as we know, because of the serious nature of the COVID disease, the severity of the underlying lung disease, most of the time biopsy may not be a feasible option. So the next best specimens include bronchoalveolar lavage and non-bronchoalveolar lavage. Again, bronchoalveolar lavage, bronchoscopy being an aerosol generating procedure, it was not usually done during the COVID pandemic. The non-bronchoalveolar lavage samples include a deep aspirated specimen from the bronchial tree or sputum. The biomarkers, that is the galactomannan and manoprotein assay, was done on BAL and serum samples. This point in time, I would like to project this new method, which is the Tripathi method, which was published from our institute by our own Naresh Tripathi sir, which has shown good specificity and sensitivity in the point of care diagnosis of invasive pulmonary aspergillosis. Now, based on these features, that is the clinical features, radiological features, and mycological features, there are too many definitions and too many criteria available for the diagnosis of pulmonary aspergillosis. But many of these have various drawbacks, which include difficulty in obtaining samples, the lack of biomarkers. Some of them are introduced only for research and clinical trials. So at this point of time, we have formulated a new practice guidelines with the help of the Department of Radiology, Microbiology, and Hematology. That is a new practice guidelines for diagnosis of CAPA in intensive care setting, which was published in the Journal of Intensive Care Medicine. As per these guidelines, we have categorized our patients into suspected CAPA, possible CAPA, probable CAPA, and a definite CAPA. Those patients who have clinical features or risk factors, which include refractory fever, hemoptysis, pleural rub, on immunosuppressive therapy, along with radiological features suggesting of invasive aspergillosis, were considered as suspected CAPA patients. When these suspected CAPA patients, if they have positive fungal biomarkers, that is galactomannan or manoprotein in BAL or serum samples, they were termed as possible CAPA. If they have direct mycological evidence in the form of direct microscopy culture or PCR, they are classified under probable CAPA. With these features, if we were able to attain a histopathological diagnosis in the form of a biopsy, we term them as proven or definite CAPA. So based on this diagnostic criteria, we have done a study on the COVID patients admitted to our Rajdhani COVID hospital, which include a total number of patients of 1,161 intensive care patients. This was an ambispective study, single center ambispective study from March 2020 to August 2021, which include both the first wave and second wave. The first wave was a retrospective study because the disease entity of CAPA came into the diagnostic criteria. Everything was formulated by the end of the first wave. So most part of the first wave, we were unaware of this disease entity. By the end of first wave and by the beginning of second wave, we have our own diagnostic criteria with us, and all the diagnostic modalities were readily available with us. And the second wave was a prospective study wherein we looked for the clinical features, and we were intensely looking for CAPA patients. So the study period was from March 10, 2020 to August 28, 2021. Among the total COVID-19 patients hospitalized in our Rajdhani hospital, which is 3,583 patients. The first wave, which was from March 10, 2020 to February 28, 2021, we had 2,459 patients admitted, among which 1,014 patients were requiring ICU care. Out of this, 817 patients were enrolled in this study. As I have already mentioned, this first wave study was a retrospective study. During the second wave, which extended from March 1st to August 28, we had about 1,124 patients hospitalized, among which 478 required ICU care, and the number of patients enrolled in the study was 344. In the first wave, the prevalence of CAPA was 1.6% with a mortality of 53.8%. The decreased prevalence may be because we were unaware of the disease condition and we were not actively looking for CAPA at that point of time. During the second wave, the prevalence was 17.7% with a mortality of 45.9%. During this point of time, during the second wave, we were all aware of the disease entity and we were actively searching for the disease. Also, this is during the second wave where there was inadvertent use of pulse corticosteroids, immunomodulators in the treatment protocol, which might have also caused for an increased incidence of CAPA during the second wave. So the overall prevalence of CAPA was 6.4% and overall mortality in CAPA was around 47%. So the demographics of our study, the median age of both CAPA and non-CAPA patients were around 55 with 1/3 of female population. The main clinical symptoms included hemoptysis, persistent fever, chest pain, and ARDS at the time of presentation. Among this, the univariable analysis showed significant correlation between the symptoms of hemoptysis, persistent fever, and chest pain. However, in multivariable analysis, hemoptysis and persistent fever showed significant correlation. The ICU parameters which we have considered is the duration of hospital stay, the type of ventilatory support, that is the invasive mechanical ventilation or non-invasive mechanical ventilation, or the non-ventilatory support. Our COVID patients have the spectrum of comorbidities associated with them, which includes diabetes mellitus, hypertension, chronic disorders like chronic lung disease, liver disease, kidney disease, renal transplant patients, malignancy, and HIV patients. Among the spectrum of all these comorbidities, diabetes mellitus was found to be significantly associated with the development of CAPA. Among the CT findings, cavitation, consolidation, and nodules. These were found to be significantly associated with the seen in among the CAPA patients in the multivariable analysis. Among the laboratory biomarkers, increased leukocyte count, prolonged lymphopenia, thrombocytopenia, elevated CRP, D-dimer, and fibrinogenemia were all associated with CAPA in the univariable analysis. However, in multivariable analysis, leukocytosis and prolonged lymphocytopenia were the two features which were seen associated with CAPA. The anti-COVID treatment, in the two waves, patients have received various anti-COVID treatments, including remdesivir, HCQ, azithromycin, steroids in the form of dexamethasone, methylprednisolone, tocilizumab, immunomodulators like tocilizumab. 17 of our CAPA patients received pulse steroids, and 6 of our CAPA patients received tocilizumab. So this was the breakup of CAPA patients seen in our Rajdhani COVID hospital. We had 3 proven CAPA patients, that is histologically positive for Aspergillus. There were 51 probable CAPA patients, those patients were having clinical features, radiological features, and culture or PCR positive. And 21 possible CAPA, those patients which were having strong clinical and radiological suspicion, along with fungal biomarkers, that is galactomannan, which may be ball galactomannan or serum galactomannan. Among the probable CAPA patients, the total number was 51, and these were the species identified. Aspergillus fumigatus was the most commonest, which was isolated from 29 patients, and there were multiple species seen in 9 patients. 34 of the patients were culture positive, 7 of them were both microscopy and culture positive, and 10 patients were positive for Aspergillus PCR. Among the possible CAPA patients, the various radiological features included consolidation and GGO, that is the combination of various radiological features in the form of consolidation, GGO, nodules, and cavitation. And the biomarkers positive were galactomannan and manoprotein. So how to differentiate between CAPA and colonization? For the diagnosis of CAPA, clinical and radiological setting is very essential, and there will be positive fungal biomarkers, that is galactomannan and manoprotein. The raised IgG antibody to Aspergillus more than 0.27 is a feature of colonization. Now, coming to the various CAPA associated risk factors, which was shown significant in our multivariate analysis by binary logistic analysis. The underlying uncontrolled diabetes, clinical features of fever and hemoptysis, radiological features of cavitation, consolidation, and nodules, an elevated leukocyte count of more than 11,000, and persistent lymphocytopenia of less than 1,000. These were the significant factors, risk factors associated with development of CAPA. And regarding the mortality factors, ARDS at the time of presentation, high CT severity index at the time of presentation, elevated total leukocyte count, and persistent lymphocytopenia, that is less than 1,000, were the significant mortality factors seen in our study. This is the Kaplan-Meier curve plotted for the various categories of CAPA. Here we can see the mortality in possible CAPA is much more than that of proven and probable CAPA. This may be because of the late initiation of targeted therapy or specific antifungal therapy in possible CAPA patients. The mortality was significantly high in CAPA patients when compared to the non-CAPA patients. So here we can see the difference between the possible CAPA and proven and probable CAPA, and also between CAPA and non-CAPA patients. Now, coming to the group of patients who have received pulse glucocorticoids, it is seen that among the CAPA patients who have received pulse glucocorticoids, the mortality was significantly higher than those who have not received pulse glucocorticoids. However, among the non-CAPA patients, the mortality was less among the pulse glucocorticoid treated patients. Here we can see among the CAPA patients, the use of pulse glucocorticoids was very detrimental, and that has caused a significant rise in mortality. However, among the pulse glucocorticoid treated patients among the non-CAPA category, those patients who have not received steroids was shown to have higher mortality. Now coming to the immunomodulator group, those patients of non-CAPA and CAPA who have received immunomodulators have got significant higher mortality. However, we could not establish this among the CAPA statistically among the CAPA patients, maybe because of the less number of patients. That is, we had only 6 patients who received immunomodulator. So to summarize our study, the overall prevalence of CAPA was 6.4%, including the both waves. The overall mortality was 47.3%. The Aspergillus fumigatus was the most common species isolated in our center, and the clinical features, which were persistent fever and hemoptysis, were the most common clinical features seen among the CAPA patients. And diabetes mellitus was a significant risk factor for the development of CAPA. The CT features of cavitation, consolidation, and nodules should always arise suspicion of invasive aspergillosis. Neutrophilic leukocytosis and prolonged lymphopenia are associated with CAPA. The concurrent diagnosis of CAPA with COVID-19 was rare. A median of 11 days after ICU admission is the time when CAPA was diagnosed in our study. Most of our CAPA patients had no ARDS or any ventilator support. That is, about 47% of our patients were having ARDS. Rest of the patients were not on any ventilator support. Like any other viral infection, COVID-19 in itself is an independent risk factor for CAPA, and all COVID-19 patients, whether severe or non-severe, should be systematically screened for this disease entity. There was substantially higher mortality in pulse glucocorticoid treated CAPA patients, but significantly lower mortality in pulse glucocorticoid treated non-CAPA patients. So the use of pulse corticoid should be very cautious if we are suspecting an invasive fungal infection. Though we could not demonstrate a significant effect of immunomodulators use on mortality in CAPA due to the very small number of patients, but it is seen that use of immunomodulators have caused higher mortality among both CAPA and non-CAPA patients. In order to further look into the effect of pulse steroids and tocilizumab on development and mortality of CAPA, we are already in the process of meta-analysis, which will be published very soon. So if COVID was an earthquake, CAPA is more like a tsunami that follows when the COVID virus and Aspergillus spores shake hands. Thank you.
At